Back to week 3, comparing cohorts and propensity score matching. I think this is where we really start to get into some exciting stuff, but I think everybody really wants to get to next week where we do our conducting outcomes analyses. But I think starting with comparing cohorts and propensity score matching is going to be really essential for understanding what we're doing. Here are our overall bootcamp objectives that we've covered a couple of times. Today, actually, I forgot to update these, but today we're going to be really moving into choosing an analysis tool, getting into our index events and seeing what that is and what that means. Looking at cohort comparisons, using baselines and balancing cohort functions to see what's going on in our differences between cohorts, and propensity score matching, which is I think a really sophisticated and a great way to make sure that the study that you're putting forth isn't junk, that you're really finding paired groups, and you're really able to, in some ways, create good quality quasi-experimental studies that comport with how we do science in other areas. So this week, as I said, we're going to be comparing cohorts and propensity score matching if you've been following along in our rapid development process. And we're still around here if you're doing the even more rapid process that I described earlier on, which is pulling out key features from articles, reconstructing the study in TriNetX, and refocusing the structure in your topic. And now we'll be getting even into examining your outcomes. So yeah, this week we're getting more out of the foundation and into the house itself, right? Your analysis, cause and effect orders, and propensity score matching. In my clunky metaphor, we're getting into that, into constructing the house itself. Recapping a little bit for those who couldn't join us or have been following along. This is the study I'm doing in parallel with this to show you how I've been working through these and how other people do their studies. Comes from a bunch of internet clownery out there related to Alzheimer's and statin prescription, where this guy claimed that statins are causing higher rates of Alzheimer's with really no evidence for that. In fact, there are a number of really good quality studies that refute this exact point, that show that statins may even have a protective effect against Alzheimer's because of some of the inflammatory mechanisms that are potentially causing Alzheimer's, as well as a number of other issues like reducing vascular dementia, which contributes to but is also different from Alzheimer's. So anyway, this is kind of what we're doing in the background, is examining whether statins impact people's odds of developing Alzheimer's disease. So I've got these little hypotheses that I'm testing as we go, trying to set this up as scientifically as possible. So now our cohorts are done, right? We are now moving into the analysis phase. We have really thought about who needs to be included. We've set up all of our relationships over time. We've been as clear as we can in our definitions of how long people have been on drugs. We've checked and used our explore cohort function to see whether there's anything going on. And we've got 2 really nice cohorts here. We've got our no statins, people who have not ever had any statins, have no comorbidities for Alzheimer's in their records. And we have a second group, that's our control group. We have a second group that's have been on statins, at least one statin, have no major comorbidities, and have been on that statin for at least 1 year or more prior to the record getting started. So it may be time now. I think we're in a good position, as as confident as we can be in our cohorts, to move on to the analytics. So you can see when you click on the analytics button, it'll show you, in this case, I've got a bunch of different analyses running. You're going to see a button in the top right that says new analysis. And that is the new button that takes you to a bunch of different analytical tools in there. I got compare outcomes noted as the best one because it's my favorite, and it does some of the most useful stuff in the platform. But you can do all sorts of other stuff. There's analyze outcomes, which compares people within one cohort and sees what rates are within a cohort. This is common for people who say, I just want to see whether what the rates of kidney failure are in this population of people. That's cool, but all of those functions, by the way, are available in the compare outcomes function. You can compare cohorts in there as well. If you don't have an outcome and you just want to see whether two cohorts are different, you can use that tool to do it, to do compare two groups and see whether one has higher rates of kidney failure than another. If you have competing risks, you can look and see within a group whether those risks impact groups, whether they lead to higher rates of a particular outcome than other folks, than other kinds of things. Treatment pathways is a super cool tool that if you have a particular interest in whether people received one drug before another or received one set of drugs or therapeutic techniques versus another set of therapeutic techniques, this will allow you to compare those and to see what kinds of outcomes people had on let's say, one set of cancer drugs or therapeutic approaches versus another set, or if somebody had let's say a surgical procedure versus somebody who didn't, what their outcomes are like. Similarly, incidence and prevalence over here is really useful if you want to see whether, in particular, specific changes to quality of care or specific introductions of different drugs at specific points make changes to outcomes. A lot of people have used it to look at COVID, but the problem is if you're looking at things like, did rates of hypertension increase during COVID? Well, no, everything declined going into COVID and shot back up coming out of COVID because everybody was sicker and needed more care. So I actually don't recommend this, even though you could use this for a bunch of different kinds of COVID studies. I have tried like 5 or 6 different studies that would compare incidence over time, let's say pre-COVID, during COVID, post-COVID, and they all kind of show the same thing, which is that V-shaped curve in there. So you can use it for COVID-based research if that's something you're interested in. But it's more interesting for stuff like if a standard of care or a drug, the introduction of a new drug changed the way prescriptions should have been going, you can look and see whether from 2015 to 2019, the number of prescriptions of a particular statin, for example, increased versus the following 4 years from 2020 to 2024 or 2023, whether those changed, whether the prescription patterns changed during that as well. So it's a very useful tool, but a lot of people try to use it for COVID in ways that probably aren't that interesting. The Advanced Explore cohort function also has some neat capabilities that are related to time that you can use as well. But typically anything we would use this for, we'd probably use the compare outcomes tool for as well. So just really quickly, there's no best tool, even though I say that that's my favorite or the best one. So what I'm going to teach you today, teach you about today and next week as well. There's no really one best tool. And it really, the right tool depends on having a clear and focused research question. Is your question about time, order, or sequence? Well, then you're going to use probably treatment pathways or advanced cohort explore. Is your question about outcomes? Well, then you're going to want to use the analyze outcomes or compare outcomes group. And is your question about relative risks? Well, if that's the case, you might want to use your compare cohort groups to see who's more at risk of getting a particular disease. Again, just a quick summary, if you want to take a screenshot or refer to this later, of the kind of blurbs for all of these tools, if you want to consult with that. But cohort comparison, why cohort comparison? Well, I think it's really great because it really can help you function sort of like a randomized controlled trial. It has, and we're going to talk about some of the features that mimic that methodology. Now, RCTs are great because they are prospective, meaning that we're controlling a variable. We're eliminating all variables from our pool except the ones we're interested in and are relevant by selecting the right kinds of people and that kind of stuff. This uses a retrospective approach to analyze things in the same way. And propensity score matching is one of the core tools in that we're going to talk about today as well. But One of the other reasons that I really like compare outcomes as a tool is, number one, it forces you to think about your outcomes, not just doing a descriptive study of like, oh, what percentage of people have this versus that. That's cool, but thinking about how this impacts some other future health state is really powerful. And you can use this to control and limit confounding factors really nicely. And we're going to talk about that. It allows you to compare cohorts like the analyze cohorts tool. And it also allows you to see competing risks like the competing risks tool. And you can do all of that within this one tool. And in fact, you kind of have to do it to do a good job of it. So once you've selected, and I'm going to show you how this looks in the system in a minute, but once you've selected your compare cohort functions, you're going to see a similar look to some of the other things we've done in the past. You're going to see a screen that looks like this, and you're going to be able to, let me just call it my TriNetX study here, because it's a little easier to show you how the interface does this. But basically, you're going to be able to drag and drop your cohorts into this purple and this green slot here. And the reason that's so useful is it allows you to, sorry, I'm just going to go to my cohorts here. When you click on it, one of the great things about this is you can really easily swap out your groups just by clicking, X on this one. And let's say you realize as you're conducting your analysis, that you've made a mistake and you want to swap in a new cohort. Let's say I've got my version 3 of the cohort here. Maybe I want to put that in. So you can just quickly drag and drop it, swap out. Oh, okay, I want to, getting an error, of course. Try this, third time's a charm. So you can really easily, you can see I swapped in that group. I'm going to go back here, and I'm also going to swap in my other group. This is version 4 of my cohort. I've been trying and working on it over and over again until I get it. So you can really easily copy. One thing you can do in the analysis screen is also duplicate these projects. So once you've got your project in a really good place and you've got the analysis good, you can make another copy of the project and swap out the cohorts really easily to conduct further studies on this. So over here, you can see these great tools on the side of the compare cohorts function. The first one is characteristics. These are actually going to remind you a lot as we go through this of some of the functions, the doctors don't pay money late functions that we talked about earlier. But before we can even use any of those functions, you have to set what's called an index event. I want to talk about this for a second because it's actually a bit confusing, I think, for some folks to understand what we mean when we say it's an epidemiological term. But basically, this characteristic window allows you to do two things related to your index event. It allows you to set a specific time frame going into the past. Next week, we're going to talk about looking into the future, but this time we've got our time machine, our DeLorean here, and we're looking backwards into time. Now, the question is, backwards from when, right? What is the event that marks the 1985 about? I'm dating myself with references to moving Back to the Future, but what's the event that we're looking back in time from? Well, the index event is an event for each cohort where it's the starting point of the analysis where whatever features have been checked, whatever boxes have been checked, serve as the first date that those events, that this person gets entered into the cohort. So in this case, the first date, the index event that enters people into our study is the day that they're prescribed an ibuprofen, an aspirin, or have an ambulatory visit, and they're 45 years old. And all of these things will always have been untrue about them, meaning this person, any person entered into our cohort, will never have been on a statin, never have had a stroke, never had type 2 diabetes, never had Parkinson's. So the day that they enter our cohort is the first day that they have an aspirin or an ibuprofen. Similarly, over here, the day that the people enter into our cohort is the first day they have an ibuprofen and have had a statin for at least a year. So people who had a statin for 360 days wouldn't be included in our cohort. They had to have been prescribed the statin at least 365 days before they got the ibuprofen. It's kind of a little confusing, so I just want to show you. TriNetX has a really nice set of help documentation and diagrams that I want to show you. That I actually stole this drawing from them. But here you can see, in this case, an index event. Like here's a series of patients, right? This patient on January 16th had asthma. This one was given albuterol on April 16th. Then there was nothing. Then they were given a series of other drugs, and they were given a series of and they had a series of other symptoms that were prescribed. So you can see that the pathway, the journey for each of these people is different, right? They're sneezing. Some people started out on January 16th with sneezing. These two people started with asthma. This person was diagnosed with asthma on April 16th. So you can see that if asthma is your index event, then different people enter into the study at different times in their illness sequence. So this person is having sneezing, wheezing, and cough for a whole year up until they are diagnosed with asthma. Whereas this person is diagnosed with asthma, and then they're given albuterol, and then sneezing, wheezing, and cough, and such goes on like that. Similarly, if albuterol is your index date, that exact same sequence of events that you might see looks different, right? The person enters into our cohort on April 16th. This person enters in on July 16th. This person on October 17th or 17th. So it can really impact when people enter into your study. So here's the first time the patient has cough within 6 months after wheezing in their records. You can see it's really particular. But here is wheezing, 6 months later cough, wheezing, 6 months later cough. Here's wheezing, then cough, but that came at a different time chronologically than those people. So that's kind of how index events work. They impact when the person starts in your study. That's a little weird, and I'm not 100% sure I gave you a great explanation of that. Does anybody have any questions about index events before we proceed? I'm gonna try to get back into my.
Hello, good evening, Dr. Novak. This is Amrita. I was wondering about combining severity with the index case. So, for example, if we were to only look at severe asthma, for example, is that possible?
Yeah, so it depends. Would you be using the ICD-10 code for severe asthma in that case?
That's possible. Also, it's based on certain guidelines and the degree of support. So the use of medications also influences
Okay.
the diagnosis.
So yes, you would have to. It would probably if that was your defining event in here, then yeah, you would have to mark it. Now you could say if let's imagine severe asthma was one of our characteristics in here. You could just say that by checking this box, it means the person enters in. Let's imagine that this said severe asthma over here. That this person would enter when they have severe asthma. However, you could also say if severe asthma is not the defining feature of when the person enters the case, if that's not the trigger event, the index event, then they would just be a person with severe asthma who's in the cohort. But they wouldn't. It wouldn't wait to enter them into our study until they had been diagnosed with severe asthma. If you check the box, they won't enter into the model, into the thing, until they've been diagnosed.
I see. Thank you.
Yeah, thank you. That was a great question, and it's a little all over. I know it's kind of a simple concept in some ways, but in other ways, it has a lot of really profound implications for what happens in your study and how the platform interprets and how you can interpret your results. But let's say for my purposes, I'm going to enter everybody in, and I wanted to show you all some of the cohort comparison functions in here. So you saw a moment ago, much like what we're going to do later when we compare our cohorts. Right now, compare our cohorts along an outcome. Right now, we're just going to hit the run button because what this is going to do is compare the cohorts in terms of their existing characteristics. So later on, we're going to look at whether belonging in one cohort or another exposes you to a higher level of risk for Alzheimer's disease. But right now, we're just looking to see whether there are any population level, any characteristic level differences between our two groups. So I'm just going to let that thing run for a second while we do it. And this goes back again to our doctors don't pay money late approach. As you are going through your study, you really want to look at your demographic comparisons. You want to look at your diagnoses, your procedures, your medications, and your labs to make sure that there are no confounders that maybe you wouldn't know about from your literature. And my most common examples of that are age and sex. So I can show it to you live over here. Okay, so here, as you can see, is my cohort. You can see in this case, if you zoom in a little bit, where purple is my no statin control group and green is my statin group, you can see here that my purple group, no statins, is a lot younger than my group. So that means this number tells you they're age 55 when they enter our cohort, when the index event is true for most of the people in my group. And that's plus or minus 13 years. So they might be as young as 42. The standard deviation with that would be as young as 42 or as old as 68, for example, or 69 in that cohort. However, the average age of the people in the statins group is much older. They're 66 years old on average, plus or minus 11 years. So as young as 57 or as old as 76 or 77. It also gives you the minimum because we set it that way, and maximum. Max 90 is always the maximum because TriNetX, by the way, does conceal people's age over the age of 90. Just because the number of people who live to that age gets so small, you could theoretically identify a person who's 97 years old because there's not that many of them. So what are we to do about that, right? So I have an older group. How do I control for that? Well, the first thing to do is identify that that's one of your confounding variables. And to use this little icon here, you can see here next to all of these characteristics is a little star. And that star saves your characteristic to this little box over here. You can see, I'm just going to show you that this star puts things into that box. And that's really useful because later on, you can call up those starred items in a variety of different screens that we're going to see in a couple of minutes. So I just wanted to let you know about that. But begin to think in terms of all of the boxes that you star. In this case, you can also see that our groups are disproportionately, our no statin group is more female than our statin group. Well, that could confound things. Men have higher rates of Alzheimer's overall. Men have higher rates of every manner of negative outcome. So we may want to control that in our population to make sure that, let's say, folks who are higher in age and who are sicker are not being confounded or that's not becoming a confounder for what we're looking for, which is the evolution of Alzheimer's. I mean, not everybody who's older or male gets Alzheimer's. So there has to be some other characteristic that's defining that. So making sure that our cohorts are balanced in male and female groups can help to remove, or at least let's say they're not balanced. They are randomly distributed in male and female, will really help us make sure that we're not confounding that variable, that we're actually finding the cause to be the thing, to be the statin or not the statin. So by checking this box, it allows us to call on those things later. Now, similarly, later on when we're looking at our diagnoses, just to show you, you can dig down and, well, that's loading out. There we go. You're going to see in the screen an additional function in addition to the star that is really, really useful. This feature, you can see this little button that says signal over here. It looks like, a cell phone bar, right? Is really fantastic because it allows you to really quickly visually see whether something is different between the two groups. Now you can see here, obviously, the purple group, our no statin group, is only 5% on this variable, but the other group's 43%. So you don't really need, it doesn't take a rocket scientist to see that one cohort has higher incidences than that the green cohort has higher incidences than the purple cohort. But this button for more subtle differences, especially on cohorts that are differently sized, it can be very valuable to have that little signal icon to tell you what you're seeing. Similarly, here we've got abnormal findings on diagnostic imaging and function. Well, yep, looks like that's still the case. And what's nice about this is you can still continue to drill in and find where the difference in the cohort is coming from. So 3% of people have abnormal results on their cardiovascular function. What's going on there? Okay, so they had an ECG or an EKG, something's going on. Is that theoretically relevant? You can then do the work, the cognitive work of deciding whether that fact is relevant to your study. I'm going to say, even though it's a pretty strongly quantitative difference, it's probably not the thing that's driving any anticipated differences between my two cohorts. But that, a lot of people ask me, when should I save a characteristic? And I'm not an expert, but what I would say is you should save a characteristic using that star icon. Not just because the number is really high or whatever, but you should understand, you should look to see for characteristics that are plausibly relevant to your differences in your outcomes in your cohort. As I said, though, ones that do have a strong signal or a large proportional disparity between the two groups. And really, is it something you want to control for in your analysis, but don't want to exclude the whole population of people with that characteristic? So for a lot of cases, if you were doing a study of, I don't know, insulin resistance or something like that, people have to take progressively higher and higher levels of insulin, you probably couldn't rule out or exclude everybody with hyperlipidemia because those comorbidities are really linked. However, you may want to control for it in your study and make sure that you have a random distribution of people with hyperlipidemia and without within the study. So you don't wind up, unless you want to conduct a study of people with hyperlipidemia, you have to go back and redo your cohorts. If you are able to control for these two things, it really helps avoid confounding variables in your study when you're doing your propensity score matching in a minute. So yeah, this would be true. I would recommend going through all of your medications, your procedures, going through all of those to check and see if there's anything in there that you need to control for. Another item another kind of thing I might suggest is it's generally better not to select the highest level item in a study unless you wanted to save anybody who ever had a surgery. Those top level categories are a little too broad to be meaningful for your future propensity score matching or other kinds of analysis, your baseline comparison analysis that we'll be talking about in a second. They're too high level. So, I would suggest, generally going a couple of layers down and making sure that if you're interested in vascular introduction and injection procedures, that's probably going to get you more of what you're interested in than the arterial procedures that you might be looking for. You might be looking at, than the surgical procedures that you might be looking for. So generally don't pick stuff up at this level to star. It's too broad. There are too many confusing things in there that could mess up your study. Try to go down a couple of layers and really identify, in this case, it's probably not the arterial procedures, probably vascular introduction. So I guess a lot of people getting atherectomies and other kinds of stents and things like that. That's probably a little more relevant than if somebody had their big toenail removed 5 years ago for unrelated reasons. That's just a thought. Another thing is, now that we've gone through, you can see over in my saved characteristics function over here, that it's moved all of those items that I starred, male, female, age and index. I also included, for my study, it's unclear if psychoactive substance use, how it and what they mean by psychoactive substance use, how that contributes to Alzheimer's disease. I mean, clearly, if you're doing, if you're smoking a lot of meth, you're probably doing a lot of different kinds of damage to your brain. And some of that may be related to Alzheimer's. For example, if indeed sleep is a core part of Alzheimer's, the driver of Alzheimer's, then doing a lot of meth is counterproductive to sleeping, which is probably going to lead to tangles of proteins that aren't getting cleaned out in your brain if that hypothesis is correct. So rather than going back, though, and excluding all of the people who might have done psychoactive substances, I don't know if they ever used cannabis at some point in the past. We may not want to jettison all those people, but we may want to make sure that, especially since it's a fairly small number of people, that later on we are accounting for that statistically in our propensity score match. But before we get there, what I want to show you is this tool, because I know this is going to be useful to a lot of people, where once again, we want to go a step beyond what we were previously doing. Oh, I think I have too many people in this cohort. Let me show you in the other version, in the PowerPoint version here. What you do is when you hit this run button, I have too many people in my cohort to be able to run this exact version, because I have 22 million people in this cohort. Probably isn't going to run that well. So I'm actually just going to uncheck an option here. Let's see if it'll run now. Nope. I want to keep that, but I can remove female. Nope, still too many people. Okay, that is the thing to be aware of. By the way, if you read this error, there are limits to the computing power available to do this. If you have a cohort, in this case, we have a combined cohort of like 24 million people. With two covariates, we have like 8 million data points that it has to run, and that's too much. So just an FYI, having gigantic cohorts like this one I defined, my version 3 of this cohort, makes it hard to do certain kinds of analyses later on. It can break the mathematical model. I'm going to show you this smaller cohort I had until a while ago. It has about 2 million people in it in the non-statin group, and 148,000 in the statin group. So what happens is when you hit that run button, it'll essentially do that statistical comparison for you. So when you're writing up your paper, you can say that when you were looking at whether it's cancer rates, or in this case, important differences between the two groups in terms of their outcomes, it'll run a t-test for you that allows you to look at it and see that there is a statistically significant difference between group 1 and 2 along its male-female distributions, and also in age. And that can be really valuable when you're reporting this out in your journal and you want to describe the differences between your groups. And also it gives you your mean, your p-value, and your standard difference, your standard deviations, as well as the percentages of the cohort. So that's enough to report in most journals in terms of the stats for your, in this case, it's a z-test. Does anybody have any questions on that before we move on to propensity score matching?
I just had a question. How do you run other tests other than t-tests? Like, for example, like Wilcoxon-Rankin test, other data comparison.
Some of those, like, for example, when we run the propensity score match, it'll run a logistic regression between the two groups to see if there are any differences. But no, you can't select specifically a test other than a z-test. And to be clear, it's a t-test, unfortunately, gets broken at scale, population scales this large. So it is a z-test and produces a z score.
Sounds good. Thank you.
So yeah, you can't do a assigned rank test or anything like that. Though there may be other places that generate that as well. Some of these things, by the way, you can run if you, let's say, put them into SPSS and ran that, or into Excel, depending on the kind of test you want to run. I have run logistic regression. There was a study where we were looking at rates for Black, Latino, and white folks on rates of atherectomies. And so really simply, I put those into a regression model, and I was able to run and determine whether that, in fact, when you account for some other comorbidities like age and sex and dichotomous variables or binary variables like male and female, you can actually show, you can run that as either a binary logistic regression or a logistic regression regression analysis on variables that you've or score values that are generated by TriNetX as well. Okay. Well, let me know if there are any other questions. That was a good one. Next up, I want to talk a little bit about propensity score matching because I've made reference to this probably 10 times already. But let's talk about what is propensity score matching. So propensity score matching, I found this really great graphic on the internet from this Core IM website. But they compared it to randomization. In an observational study, if randomization is to a randomized controlled trial, propensity score matching is a tool for avoiding and reducing bias in observational data. So randomization is how we do that in a prospective trial, but in a retrospective trial, we can use propensity score matching to make sure we're not picking people that we already know or that may skew the data in some way. More technically, it's a quasi-experimental method in which the researcher uses statistical techniques to construct an artificial control group by matching each treated unit, that is in this case, people with statins who develop people with statins, with a non-treated unit of similar characteristics. So using these matches, we can estimate the impact of an intervention. A real quick non-technical description of that is once we've decided on our covariates, once we've decided what we wanted to star in our set of factors as our baseline characteristics, we can use the propensity score that's derived for each group. So the statistical model, the logistic regression that's run on these two groups, assesses whether an individual is more or less different from any other individual that's selected. And what it does is basically go through and it goes down the line and it picks one person from that are matched with another person based on their characteristics. So you can kind of see here we get, a female older person with a male older person and a female older person on statins with a female older person not on statins. Then you get a male older person not on statins, female older person on statins, and it just keeps going down that list until it's matched as many people as it can from both groups. And that way, when you look at it, ideally, they're randomly distributed, and there's no statistically significant difference between the two groups. They're indistinguishable, randomized. They're not exactly randomized, but there's no systematic differences between the two groups. One of the challenges with this is that, it's really effective. It's been statistically assessed for decades. It's very good. But one of the challenges is that you need a big enough sample size so that when you've done your analysis, you have enough people left over that can be matched into the study. What I mean by that is, since it's a one-to-one match, if you have 20 million people in one cohort and 150,000 people in another cohort, what TriNetX is going to do to match them is pick, let's say, whatever the smaller group is in this case. There's 150,000 people. It'll pick 150,000 from the 20 million people and match them up one-to-one until it's created a cohort. So you lose 19,850,000 people from cohort 1 in order to get your propensity score matching, because it has to be done one-to-one. So that can be bad, but it also runs the residual confounding values for you, so you can make sure that you're not missing stuff that might be still part of the study, and you get a lot of value for your trade-off between your two cohorts. So that's propensity score matching. Does anybody have any questions on that as a methodology? A big picture methodology like that?
So Dr. Novak, is it basically like if you said 125 versus 1 million, it would only pick the 125 and leave the rest.
Exactly. It'll try to match them from the group. Sometimes you end up with like a little less than 125,000, for example, or 150,000, whatever your smaller cohort is, because it can't find a similar person in the pool of 20 million. But if it can, it will match 100% of your smaller cohort to as many people as you have in the other cohort. So yeah, that's right. You would lose 18. But as I often say to folks, it's better to have a smaller cohort of the right people than a larger cohort that's got a bunch of randos in it who are not contributing to your analysis.
Do you have a number that's optimal for a like number of populations in a cohort?
Bigger is often better. But no, I would say, the problem is once you start getting below 100, having one person more or less in any direction is going to throw your numbers around a bit. However, I worked with students who are working on really unusual or rare diseases where sometimes you only get a few thousand cases in the whole world of a particular set of conditions. So you might wind up with like working on 200 people in that really narrow pool. But, like I often say, try getting those 200 people in one health system at one time so you can run a prospective study on them, right? It can be really challenging and expensive.
Got it. But like in general, like if you have a common condition, but you're trying to find something uncommon in that, would you say more than like, would you want a population which is like 100,000, that kind of thing, versus having it in thousands or hundreds?
I think, yeah, I mean, if you can get 100,000 people, I mean, for example, something like asthma or, Crohn's disease, you're going to get several 100,000 people with those conditions.
Diabetes.
Diabetes, you're going to get literally millions of people, 12, 15, 20 million people in your cohort. Now, if you're like, I want to see people with diabetes and this rare skin condition, then you might only get 500 people. But if that's who you're interested in, that's okay. But yeah, I mean, for large scale chronic illness research, that is probably the way to go, is a tighter but accurate cohort. But yeah, I would say if you can make sure that your cohorts are bigger than 500 or 700 people, then at least a nationally representative statistical sample for surveying is something on the order of 2,000 to 3,000 people in the United States. So, if you can beat that, then even though you're not trying to be representative, you can be pretty assured that your confidence intervals are going to be reasonably robust, which is something that editors look for in papers.
Got it. Thank you.
Cool. Lots of questions. I know propensity score matching. I am still working on explaining this more effectively to folks, so thank you all for your patience on that. So yeah, one thing to let you know about the propensity score matching. Sorry, I'll switch over to that in a sec. All of your starred characteristics that you selected earlier get added into this. You can see over here, actually, you get a couple of really cool things with this function as well. It's under your balanced cohorts tab over here. You can see this here. One thing you can see is that, among other things, it's nice. You can change certain ways that your variable is interpreted in your study in the screen as well, especially for the purposes of propensity score matching. So you can create categorical versions of this. Let's say you wanted to have pediatric, geriatric, and let's say pediatric, adult, and geriatric groups. So you could say a minimum of 1 year. I mean, this is going to be useless for our purposes. We could say 1 to 18. You can add another category that says 19 to 65, and then add a final category that's 66 to 100 or something like that. So this would allow you to treat age groups as categorical as opposed to treating them as continuous variables. However, for our purposes, I mean, you can also say present, absent. So male categories are present or absent because they are, you either have a gender or you don't in these cases. though that's not obviously strictly true, and these systems are very bad at accommodating non-gender binaries. But in this case, it's either present, that data is present or absent. Those data are present or absent. Here, you can have your categorical. In this case, I'm going to pick a continuous variable because I wanted to look at the relationship between age, 65, 66, 67 as a continuous variable and not as a present absent score. So once you've got your propensity score characteristics in here ready to go, you can add some as well here. So for example, I want to add female because I took that out a minute ago. It's going to take a sec to run it under demographics. Just going to go under demographics and select. Oh, you know what? I can't change that here. I have to go back to my characteristics, go under my demographics here, and start on this page. For some reason, it doesn't show demographics as a characteristic, or sorry, male, female as a characteristic you can select in this box. But just by starring it back in that previous screen, now it shows up back here. So once you do this, I'm going to see if I can get this thing to run. Yeah, I have too many people. Just give me one moment. I'm going to switch to a previous version of the study that had a smaller pool of people in it. Okay. Oh, actually, I even have my thing run. So once you hit run on this, your propensity score match is going to show you a couple of things. I won't belabor these tables a little bit, but basically this is the density, the number of people in the cohort who match these characteristics out of the gate. And then as you move up in the propensity score rankings, how closely these two groups parallel each other. That's kind of about as much as you need to know about how this table represents your data. But what you do want to know is that afterwards, there's pretty much like a one-to-one relationship between these two groups. But as I said a moment ago, you can see this cohort over here started out with 5.8 million people in it. And this cohort started with 124,000 people in it. But the common propensity score matched cohort that we get after that match is 123,000 people. So we lost like 97% of this cohort. I don't know what that is, but what the actual number is. But we lost a pretty substantial amount of this cohort in order to get a perfect match between the two along our demographic characteristics here. I include some other variables in here as well: hyperlipidemia, type 2 diabetes, hypercholesterolemia, what did I include? Oh, hyperkalemia, a bunch of other stuff as well. But what I wanted to show you here is a couple of additional features that are more useful than these graphs. The first is that your p-value that's generated by this, if you check this little box, will be really useful in telling you that before we propensity score match these groups, you can see this is the before matching column. The differences, there were statistically significant differences between the male group, the female demographics, the male demographics, and the age at index, and statistically significant differences between all of these characteristics except the mental and behavioral disorders due to psychoactive substance misuse. Well, this is one of the rare times where having a p-value of 0.001 is bad. It means that these groups are very different from each other. This group, its age at index is 80.2 years. This group is 66 years old. There's that's a 14-year difference between these groups. A lot of stuff happens in 14 years to people's brains. So before, our p-value before was 0.001 on age. After matching, though, it's 0.9965. So it's almost right on top. This one here is right 1, right? Which means that's as close to randomly distributed, or let's say not significantly different from each other as you could possibly get. So that's what we want to see. This is one of the rare times in stats, in social science stats, or in epidemiology, or any field where you want to see a value where p-value of 0.0001 is bad and a p-value of 1 is good. But that's the case because we want our groups to be truly random. Otherwise, it's really going to mess up our outcomes later. And I just want to show you guys a little bit about how this works. Just to fast forward, here's what I was saying about graphs. You can check these boxes. As I was noting, you want them to be not statistically significant after, meaning that the groups are random. But let me tell you, I'm going to flash forward to next week because we're almost done for the night, and I want to thank you all for your patience. But without propensity score matching, my groups of no statin, and no more comorbidities had rates that were half as high as our statin groups, which, if we hadn't propensity score matched our cohorts, we would find that the risk ratio is half as much for people with no statins, which would confirm what that German guy had said on Instagram, that statins are causing higher rates of Alzheimer's disease. Now you can see our cohorts on this are fairly small. Our actual number of people is small, but if you blow that up, something like 45 million people are diagnosed with Asperger's, Alzheimer's every few years. So this could be millions of people potentially. The number of people who are on statins could be increasing that number by millions if you scaled this up to the total number. But what happens when we propensity score match? Just to give you a little preview of next week, when we start to talk about comparing outcomes, when you propensity score match, the results are flipped. Actually, the rates of people with no sense, when you control for age and gender, the rates of Alzheimer's for people on statins are significantly less. That the rates for people who are not on statins are 1.5 times as high. Now, we have very small pools. To get to Dr. Gowda's point earlier, we wind up starting from 167,000 people in our randomized pool, and we wind up with 605 people developing Alzheimer's. And similarly, we have 385 people developing Alzheimer's in that pool. But it is pretty clear that if you, even in this randomly grouped chunk of people about whom we know nothing other than their demographic characteristics, that they are statins do, this would support additional research that indicates that statins do have a protective effect. We're going to talk about how to get there next week. But you can see, yeah, that our numbers are smaller. So as I close up today, just wanted to talk about other ways to control for error. So propensity score matching does do a good job of equalizing the study and preserving your power. There are things you can do, like, for example, if the chronic illness you're looking at occurs in older people, don't include a bunch of younger people in your study because they may have other things going on in their personal or genetic profile or something that's causing those outcomes. So if you're worried about people getting, type 2 diabetes, you're probably gonna look at your 45 to 65 group, 35 to 65 group in that, and 65 plus. And that'll really help reduce random, weird, very ill people who show up earlier on in their life, where the disease is atypical. So thinking about shrinking age, using demographics like that to account for that. We would have, in this study, probably lost a little bit of our early onset cases, but we'd preserve more power for our study by not having to use propensity score matching if we did things that way. You can look at groups separately. So maybe for this study, it might be a good idea to divide men and women because we're having to control for that. So it might be better to have 8 million men and 7 million women in 2 separate studies than trying to combine them and then having to reduce it down to 160 something thousand people in our 2 propensity score matched groups. And it may be better sometimes to remove confounders from your cohort rather than to try to control for them later. That really depends on whether it's possible to control. Like, once again, I removed everybody with hyperlipidemia from the study, but it may not be possible if you're doing a study that's where that's a comorbidity or a confounding factor. You may have to propensity score match for it, but if you can remove it, maybe you should, and that'll help reduce the amount of power you have to sacrifice within your study. Yeah, next time we are going to be moving on to our next chunk of our process on outcomes and stats, which is going to close up the kind of core of our TriNetX platform overview and way of approaching things. And we're going to talk about how to get to your outcomes finally, how to read your stats and interpret the different stats that the platform outputs for you. We're going to talk about Kaplan-Meier curves and what they mean. We're going to talk about, again, z-tests and how that impacts what you're finding, and also a couple of the features that can really help you make sure that you're looking at what you really think you're looking at. That's about all I got tonight. I am going to just hold on. I guess I'll let the recording keep going for a little bit in case we have any questions. But yeah, please go ahead. Either let me know in the chat, or you can go ahead and unmute and ask some questions. Otherwise, I'm done for the night. I'll see you next week with additional questions, and we'll send out this recording as soon as we can.